Thank you for that great announcement. Thank you so much. Okay, is everyone back from lunch? Looks like we're all okay. Okay. It's now, we're coming up to our next and final panel, prioritizing reproductive health and sickle cell disease. And at this time, I'd like to introduce Ms. Tiona Wolford, and she'll be a moderator for a panel. If you want to come up. She's also the co-founder and CEO of Sickle Cell Reproductive Health Education Directive, known as SC-RED. Please welcome Ms. Wolford and the panel.
Okay, hi everyone. So thank you to Dr. Rana and to Howard for inviting us and for supporting our mission to prioritize reproductive health. So I am the co-founder and CEO of SC-RED. We are only 2 years old, and we are the first and only sickle cell organization in the entire world to have a mission around reproductive and maternal health. Next slide. Okay, so this, I think the thing that I'm most proud of as a CEO is my team. It's pretty rare. I feel like as you get older, there's a pretty big divide around the warriors and the providers. But one of the things that we love about the team of SC-RED is that we have diverse backgrounds. So it's warriors, caregivers, and providers, all advocates coming together to support this organization. So our mission is to advocate for high-quality reproductive and maternal health care for individuals living with sickle cell disease of all types. That's the link to our website. And, you know, when I first started the organization, there was an assumption that we were just going to be an avenue for women to have babies. But what I've learned as an advocate, as I've evolved in this area, we know that there are so many gaps, and it's not just about pregnancy. It's about sex and family planning and hormones and genetic counseling and priapism, menopause, all of these things that you see on this screen. So these are just a few of the gaps. There's a lack of contraceptive options. There are no disease-modifying therapies for pregnant women with sickle cell. And we know that maternal mortality is a public health crisis, specifically Black maternal mortality. And we recently had data that for women with sickle cell, the mortality rate is 26 times higher than the national average. And then another gap is just lack of access to fertility services. So if you go to the next slide. I'll talk to you a little bit about how we got started. And I don't want to bore you. I feel like I know everybody in this room, and you probably know my story, but about 12 years ago, I had a bone marrow transplant. Growing up as a child, I did relatively well with sickle cell. I would get admitted maybe once or twice a year. I did struggle a lot with acute chest syndrome until I started hydroxyurea. And like it's already been said, I grew up going to a school that was predominantly white and unapologetic about the fact that they had never met anyone with sickle cell. And they was I would get comments from the administrators like, yeah, we don't know what to do with you. It would just be so much easier if you had cancer, because at least I could plan when you were going to miss school around your chemo visits. But sickle cell is just unpredictable, and we don't know how to help you. And, you know, my mom was a single mom, sacrificing, paying all of this money, and literally we were told that I should go to public school because they have more resources. So by the time I hit about 15 was when I started puberty, and that's when things kind of started spiraling out of control. I was admitted maybe once every 2 weeks. And then I would say I missed like 60% of my junior year of high school and 80% of my senior year. So I'm looking at all my peers, you know, applying to college, and of course, I wanted to go to college, but my body was just constantly failing me, so I couldn't even think about going away to school. So by the time I was about 18, my pediatric hematologist approached me about doing a bone marrow transplant. So I stayed on the Be the Match registry for about a year, and like you hear all the time, I just did not have a match. So I kind of let that go. And then my mom, who's in the audience, she's a nurse, and she had just transitioned from bedside nursing into teaching. And it was actually one of her students who came to her about this research that they were doing at Hopkins where she could be my donor. I could have a half-match donor. So I remember doing a little bit of research, and I knew that I would have to get chemo and radiation, and I knew that there was a risk of rejection and maybe cancer and all of this type of stuff. But I went to my consultation, and I told the doctor, like, I'm willing to risk anything because I just felt so defeated. I will give up anything to be cured. I just don't want to be infertile. Because what I wanted more than life was actually to give life and to be a mother to 6 children. And that concern was pretty dismissed. And I was told that I should just be glad to be alive and that I should focus on survival, and that if I kept having the complications I was having, I wasn't going to get the opportunity to be a mother anyway. I should focus on surviving, and I could just adopt. So I remember going home and doing like a Google search looking for information about fertility preservation. And most of the resources, they were geared towards women with cancer. And once I saw the cost of egg freezing, I looked for financial resources. And what I saw was a long list of foundations that would give away money for egg freezing if you had a diagnosis of cancer. So thinking now I'm getting chemo and radiation, I thought maybe one of these foundations would kind of make an exception. And long story short, they didn't. And I was forced with having to reconcile being cured or being having biological children. And it was a really uncomfortable position to be in, especially at age 19. And so I actually ended up rejecting the transplant. So I was faced with the decision about fertility or cure. And when you hear about people with cancer, they don't have to make that choice. It's fertility and a cure. So here I am, 31, infertile, and still have sickle cell disease. So about 2 years ago, I started seeing a new hematologist. Her name is Dr. Lydia Pecker, and she's actually one of my co-founders. And when I saw her, I had no idea that she was doing a lot of research in ovarian reserve and sickle cell. And she said, you know, it's been almost 10 years since your transplant. I don't understand why nobody's been keeping up with your fertility status. So she checked my AMH levels, all my hormone levels, and she called me in the middle of the day, and she said, it's worse than I thought. And if you want children, we're really going to have to freeze your eggs as soon as possible. So I did that same exact Google search that I had done 11 years ago, and it was the same thing. Everything was for women with cancer. So I had this brilliant idea that I would start a foundation and just give away grants, because I now know that it's not just bone marrow transplants, gene therapy that can impact your fertility, but disease progression and some of the disease-modifying therapies. And it was Dr. Lydia Pecker who told me that this was really a disparity and a social justice issue. So we decided to add on this advocacy piece to our organization. And then we met with Dr. Kim Smith-Whitley, and she really opened my eyes that I could not have an organization about fertility without addressing things like delayed puberty or lack of access to care for pregnant women and things like priapism. So that's how we expanded, and we became the first and only organization to have this mission. And I did make a mistake and go a little bit too fast, because I wanted everybody to know about our conference that's coming up. It's called Give Us Our Roses, and that we kind of borrowed from the labor movement slogan about give us bread and give us roses, because I feel like as a community we've really had to prioritize survival. and not quality of life. And so now that we are living longer, we have this opportunity to kind of revision and reprioritize. So everybody should join us. This is going to be the first ever Sickle Cell Reproductive Health Conference to happen in DC. It's in DC, so I kind of breezed through the slides because I wanted everybody to get a lot of time in with my panelists. I'm going to have them come up, Demetrius, Naya, and Dr. Smith-Whitley. Okay, so I'm going to let each of you introduce yourselves. So Demetrius, we'll start with you.
How's everybody doing? My name is Demetrius Wine. I'm 36. I'm sorry, I'm 35. I was just talking to my man in the back, and we got the same birthday, 7/21. So we've been talking about our birthdays coming up. 35 years of age. I'm from Des Moines, Iowa. I currently reside in Orlando, Florida, and I have sickle cell genotype SS.
Thank you, Demetrius. I'm Kim Smith-Whitley. I'm currently the site lead at Pfizer, and we are working on the global blood therapeutics legacy molecules to get disease modification for sickle cell options broadened. I previously was the head of the sickle cell program in clinical hematology at the Children's Hospital of Philadelphia, where I had the privilege of caring for over 1,000 young ones living with sickle cell.
Hello, I'm Naya Sumter. I am 27 years old. I'm a mom of one, and I am an esthetician. And what else am I supposed to say?
That's good enough.
Okay.
That's perfect. Okay, so Demetrius, I'm going to start with you. Because when I started SC Red, there was kind of this assumption that it was going to be a women's health organization. And full disclosure, it probably was going to be until I thought about you and your story, because you kind of had a really impactful story with reproductive health. So can you share with the audience?
So I battled with priapism starting at the age of 15, and I was kicked out of pediatrics at 15 because of my priapism. They thought that I needed to see an adult urologist and that I needed to see adult care because of my priapism. So at 15, I was looking at adult care, and a lot of the urologists and the specialists that I was working with or seeing, they weren't educated on priapism, nor were they educated on priapism and sickle cell. So I struggled and I battled. My priapism progressively got worse year after. Was full-blown priapism. Ischemic priapism is what it's called. And I had to have 2 penoprosthesis surgeries because of the priapism. I was getting aspirations almost every other day, going to the ER. I was erected for 32 hours one time. And I have a documentary that I created with all of this that was going on and me trying to get help with this priapism. 31 days I spent inside the hospital in Florida, and I was 28. And nobody wanted to help me. They told me I needed to see a psychiatrist because this is nothing that you just come into the hospital and say, hey, I need a surgery, because what I was fed up. I was fed up. And I wanted to get the surgery because the quality of life that I was receiving, I didn't care to live, because my whole life was going to the ER and getting needles stuck in the side of my penis to drain it. Like, that was draining me. My quality of life was down. And so I wanted to change the narrative with priapism and men with sickle cell, because I never heard anybody talking about priapism. I never heard any education behind priapism. I was never able to research and find videos that I can learn off of. I was never able to hear seminars and anybody talk about priapism. So I told myself while I was in the hospital going through these surgeries that I was going to be able to be the voice for men that's living with priapism, because it's a topic that a lot of men don't touch on because it's very vulnerable, and a lot of men don't understand it and they don't want to talk about it. So I wanted to make sure that I was being able to be boisterous and educated enough to teach about it. So I started an initiative called Save the Male Trunks. And what that is education about priapism for young men, caregivers, and adult men who live with priapism with sickle cell. And it's a pamphlet and an educational tool piece that you can use, a brochure, and it tells you steps-by-steps things that you can do before you have to go to the ER, preventative measures that you take before you have to go seek help and get aspirations and needles put in the side of your penis for it to go down, and before you have to go to surgeries. See, I didn't have the education that I needed, so I had to jump to surgery because it was just spiraled out of control. But I want to have men to understand that they can take preventative measures and live well with sickle cell and priapism before having to get these surgeries. So the doctor that worked on me with priapism, he wasn't educated. He's done thousands of surgeries, but he never done a surgery with a person with sickle cell. And usually he told me that the surgery would be 15 to 20 minutes and I'll be done. My surgery was 1 hour and 45 minutes. And when he woke me up from the surgery, he was just next to me. And he shook my hand and was so compassionate. He said, "Man, I've never seen someone so young battle with what you've battled with." He said, you've developed so much scar tissue in your penis that I had to scrape for hours and minutes just to get all of this gunk and junk. And that was from the aspirations, the phenylephrine, and the stuff that was supposed to numb it and make it go down. So I'm very grateful to be here today. When Tiana approached me with reproductive health, I told her no. And only because I was ignorant to the fact of what she was really doing, and I have a lot going on in the sickle cell community. And I'm like, reproductive health? What do you want me to do with reproductive health? But I sat in on I believe it was a call that you had, and no, it was in Florida for a sickle cell conference, and my urologist doctor was there, and he was awarded with an award, and it was there where I realized that reproductive health and priapism is one and the same. You know, it's not only for women who go through infertility, but it's also for men. And I wanted the voice of the men who live with priapism and battle with sickle cell to be echoed and loud. And I called up Tiana the next day. I said, "Listen, I'm all in. What do I got to do? What do we need to do?" And this is what we're doing: reproductive health with sickle cell, and priapism is added into there as well for the men who battle. I wanted to add that I have an educational documentary. I said that I had that documentary. I created that while going through the 2 surgeries. So the first surgery that I had to have was a shunt procedure is what they called it. So that's just when they put the pump inside your penis, and you have to like pump up on the testicle so it pumps it up and down. That didn't work for me. That whole thing was just a mess, and it failed. So 2 weeks later, I find myself back in the operating room to get a second surgery on my penis. And, man, it was, I'm 28 years old, and I'm like, this can't be life for me. But all in all, man, God had grace and mercy on me. He knew that the story needed to be told. I'm just blessed that I was able to be the vessel that can be able to tell the story, because I'm not the only one that battles with priapism. There's thousands of young men who deal with this, and they don't understand it. And I just want to make sure that we educate and push the line for people to get understanding on sickle cell, that they can live well and have healthy life with sickle cell if they have the proper education. So thank you.
Thank you, Demetrius. And I know I tell you all the time in private, but I am so proud of you. And I know I have to get you to the airport, but I have one more question. Can you talk to us a little bit? I mean, you're really seen as like the face, not just the face of priapism, but I think definitely one of the most visible men in the community. And you've been such an inspiration. And I think that I know that I am inspired, the community is inspired, but I want you to talk to us a little bit about the mental toll that it took.
Absolutely. So played a big mental toll on my mental. So like I had stated, I didn't care to live when I was going through the priapism issues. But when I did find out quality of life and I started understanding that there was more to live for than just wanting to die with sickle cell. So I started wanting to educate people, but my mind was always knowing that this was a beautiful struggle. You know what I'm saying? Like, I knew that there was something supernatural and special about me. I knew that I was different, but I could never understand it because I was going through so much pain and agony and trauma with sickle cell. In and out of the hospital your whole life, from childhood, pediatric, getting kicked out of pediatrics at 15 and having to find adult care on your own. Understanding how you need to conduct yourself as an adult with this illness if you want to live past the stigma of the age that they set for you. All of these things play a toll on your mental. I never understood that. See, in the black community, we don't know what mental health looks like. We don't know what anxiety and pain looks like because we never talk about it. And that was one of the biggest issues. I'm a black man that's never had counseling. I've never seen a counselor. So everything that I went through in my life with a traumatic experience, it was me just praying and writing my way through. I'm blessed that God gave me the gift of penmanship to be able to write and articulate my feelings. And that's what helped me with my mental. So when I started studying, I realized that mental health is much as sickle cell disease in my life, in all of our lives that deal with sickle cell. So I encourage men also for men's health. I push men's health for my men to make sure that their mind is right, that they're doing things to preventative measures, that they're having talks, that we're having healthy talks, that we're talking about our past traumas, the things that we got over. We can all live and relate from each other's story and testimonies. So for the mental part of the aspect, man, it has played a big role in my life. But for now, I like to say that I overcame 180 milligrams of narcotics. And that also played a big problem on my mental as well. So we're not understood these because of the professionals that we have that we depend on care from. They don't educate us on this. They just give us the medication without telling us the precautions that it can have on our life down the line. So I abused narcotics naturally, thinking that I needed it every day for my pain, but I didn't. And when I looked up, I was taking 180 milligrams a day just to get out of the bed and be well and handle my business. But retrospect, when I think back, I'm like, how was I even moving and outside on that much chemical throughout the day? So all of that has it plays an effect on your mental. And if we're not educated and no one's telling us this, then we spiral out of control and people are looking at us like we're crazy. See, when we go to the hospital and we have these sickle cell crises and issues, we have to advocate for ourselves. We have to fight for ourselves. We're in the middle of a crisis. And they're looking at us like we're irate, like, oh, you're crazy, you just want medicine. But that's not the case. So with all the stigmas that we face, with all the pain and the traumas that we deal with, it definitely plays a part on our mental, but we have to have healthy conversations. And symposiums like this, it's a blessing, and it's also therapeutic. I also tell people that having these conversations is therapeutic, and it will help you. But you have to be open enough to be boisterous and be able to let people hear what you're going through. So that's the mental that, my mental's good now. I'm blessed and I thank God. I overcame the 180 milligrams of narcotics. That was the biggest struggle for me. That was the biggest battle. And now I understand that I have to live a healthy lifestyle in the way I eat, the way I drink, the way I think, the way I exercise.
So let me ask you a question. What advice do you have for like young men that's going through this situation, but they're embarrassed to say something? Like they just keep it in a secret and they suffer in silence.
I deal with that all the time. I tell people to speak up, but I also understand that there comes a time in everybody's life when they will be boisterous. We can't force it on them. When I was young, I always wanted to tell my story, but I never had an outlet to. So when social media arrived, I was like this on my phone every time I'm in the hospital, you know, telling people and inspiring people. But everybody don't have that type of charisma, and everybody don't have that drive to let you know that my pain is destroying me, you know. So I say at every point in one person's life who deals with sickle cell, especially young men, they'll talk about it, and if it's not to the public and to the world, it'll be to the people that matter.
You stole my follow-up question. All right, Naya, I'm gonna go to you next. So it was brought up a little bit, but we didn't really get into it. So I'm gonna put you on the spot because I want to talk to you about dating.
Sure.
How's it been?
Dating, it's been interesting because as my esteemed panelists mentioned, because sickle cell impacts our mental health, you have to be able to have the first, before you can even think about dating, you have to learn how to date yourself and love on yourself before you can love on somebody else or tell somebody how to love on you right. So I've been in a process of kind of just learning me, so I've been dating and kind of testing the dating waters, but I haven't really exclusively dated anybody just yet. I'm just kind of focusing on myself, but it's, you know, I've had my difficulties because, like I mentioned, I'm a mother of one. So when I did try dating, it was hard. It was extremely hard trying to articulate feelings that I couldn't even sort out for myself, yet alone be able to express to somebody else the things that I'm going through. But it's imperative that we have compassionate partners. We have empathetic partners, right? Because even if I'm not able to articulate it, nonverbal communication is about 80% of the conversation, right? And so being able to listen to all of my cues, whether they're verbal or nonverbal, is huge for me, right? Like dating, it's been, you know, interesting because my first love is books, and I'm an academic at heart, and so it's been hard trying to prioritize somebody else in my life. But you know, if those are the things that matter to you, you figure it out. And so to really be able to appreciate dating, I've had to learn how to appreciate other relationships in my life, like the intimacy of friendship. That teaches you how to be a good partner. The intimacy of mother and child or father and child, right? Really appreciate your communal networks, right? Like, and being able to appreciate those relationships will be able to empower you to have a good dating life and a dating pool. Those are some of the biggest tips I say.
That was perfect. Okay, so yes, you have a beautiful son, Zach. And we have recent data, like I mentioned earlier, that the maternal mortality rate for women with sickle cell is 26 times higher than the national average. So I want you to walk us through your family planning journey. Did you have genetic counseling? Were you nervous to get pregnant? All of it.
So it was actually really interesting how I conceived my child. I was playing with my family members and said it was immaculate conception because I never really brought people around to, you know, say this was my boyfriend or put a title on it. So when I announced that I was pregnant to my family, they were like, "Who, you? You?" And I'm like, what? Plot twist? And so, but ultimately, I was in my senior year of undergrad at St. Louis University. I was getting a bachelor's degree in African American Studies with a minor in medical humanities. And so I actually was in the middle of an exchange program. But before I left to go to my exchange program, I had a doctor's appointment with a gynecologist. He had some special title, but long story short, he was a gynecologist, and he actually gave me the diagnosis that my womb would never be able to carry children because of they saw scarring and all type of things happening, and they wasn't sure if this was a sickle cell methodology happening, or did I have some form of an STD that might have went undiagnosed because of all the other antibiotic use I might have had. It was just a lot of question marks about fertility. And so I took it as a grain of salt, and I hopped on a plane to go to South America to do an exchange program where I was in Santiago, Chile, studying medicine and sociology. Really understanding how culture impacts disease in those different areas of like how culture impacts medicine and medical care. And so I was over there, and I came back home, and like less than 2 weeks of being home, I had conception with my child. So the running joke was, especially when I gave birth to my son, and we saw that he was, in the African American community, we definitely deal with colorism. And so the first thing my elders did was check the baby's ears to see if he was going to be dark or not. And he was so yellow, like, oh my gosh, to this day, he is so yellow. So my mom was like, is that the mailman baby? And I'm like, so my child's father is dark-skinned, but of course, we all know he was the child's father, and no DNA test was needed because his elders, like, they could recognize the baby as one of their own. And so with that, my child's father was at the doctor's appointment with me before I went out of town. And so just being funny, we asked for family planning, and because language is political, he spoke up and asked for, can we have sickle cell tests to see if I have any hemoglobin. Well, we asked about sickle cell traits specifically, and so they only tested for the sickle cell trait. And when I conceived my child and they did the Newborn Screening Act, come to find out he has hemoglobin C disease, where he took a C from me, and my child's father had beta thalassemia. And so nobody knew about my child's father having beta thalassemia because the sickle dex does not detect those type of hemoglobinopathy. So that I found that very frustrating, seeing as even with adequate planning, and I thought I had a level of health literacy, seeing as I'm a college graduate, and we still missed key factors of if we were going to have reproductive, if we were going to decide to reproduce or not. And so it was incredibly challenging, and I would say during the duration of my pregnancy, the biggest thing that helped me bring my child earthside was managing my mental, because being upset causes stress and exertion, and the baby can feel all of that, right? And so I did have a few VOC crises and acute chest crisis during my pregnancy, and so the baby did have experienced stress, and so they had to induce my pregnancy. Doctors were not very empathetic to my journey, and so I had to collect NPI numbers. I definitely had to call on my community to report doctors' inappropriate behavior, but thankfully after just reporting one doctor, the entire team got it together. And so I was able to deliver a healthy baby. Well, my baby was born with a neonatal abstinence syndrome, and so that's something that wasn't talked about as much during the VOCs when they were administering pain medicine, how the baby would be impacted by the pain medicine. So he went through withdrawal symptoms his first couple weeks of life, but thankfully, I have a healthy son, and he's here with me.
Thank you, Naya. Okay, I'm going to go to Dr. Smith-Whitley next. And Dr. Smith-Whitley, she is my co-founder, but she's also my chief medical officer. So Dr. Smith-Whitley, we've heard from both Demetrius and Naya kind of how the healthcare system maybe failed them a little bit, because there's all these conversations that should have happened and didn't happen. So from a provider standpoint, why do you think that reproductive health fell so far under the radar?
So thank you for that question, and it's spot on, because I think that many of us know that through this journey, there were conversations that should have happened that didn't happen. And one of the key features that SC Red really tries to focus on is shared decision-making and the lifespan approach. And so what do I mean by shared decision-making? It is the concept that when someone's health needs to be optimized, that it is a conversation on how best to do that. And that conversation needs to happen between the healthcare team, between the individual with the condition, and their support system. And that starts, it should start in the newborn period when someone brings their baby living with sickle cell disease to see the doctor for the first time. And that should continue across the lifespan through transition until adult focused care. One of the key features to making sure that these conversations happen about reproductive health is something called the Reproductive Life Plan. And that's addressing at every step. How can I make sure that this individual in front of me has the opportunity to have a child when he or she is ready to have a child? How can I maximize that? Well, I have to keep them healthy with their chronic health condition, right? Because that obviously is going to improve your quality of life and your ability to have that shared decision-making discussion on when you're ready to have a child. And I think that the other key feature is doing this at different times so that individuals understand how their therapies impact their ability to have children. Individuals understand how medication or practices on not to have children can impact their health, like hormonal contraception. And then getting that person across to the decision of, okay, I'm ready to be a mom or a dad now. How can I keep myself safe, and how can I make sure I'm going to have a healthy baby? And I think that that's where the healthcare system fails. And I think it's through organizations like SC Red that really discuss openly how individuals living with sickle cell disease need to advocate for these conversations and really talk about these decisions with their healthcare providers. And that requires a trusting relationship. And so all of the things that we've talked about today, stigma, right? The myths of sickle cell disease, you know, that priapism is associated with sexual activity. Not true. That women with sickle cell disease should never get pregnant because it's going to impact their health so negatively. Why expose yourself to the risk? Not true. So we know that there are ways that you can have a healthy pregnancy. We know that there are ways that you can preserve fertility across the lifespan, and we need to make sure that we're advocating for that at every step. And it never stops. It really never stops, because reproductive health is something that goes into the elderly. We have to understand how menopause impacts women with sickle cell disease. Very little data on that, right? So these are things that we need to continue to have conversations about, and I'm just glad that there are organizations like SC Red that can help us advocate for this.
Thank you. So my second question, I'm curious to know, as co-founder and chief medical officer, what's been one of the most eye-opening moments for you since we started?
I have had so many eye-opening moments. It's really, I just need to take a step back and do something that she's going to be upset about. But I just need to just say a few words about Tiana. And when you come into somebody's presence who is so inspirational, so energetic, so much about self-advocacy and raising the voice of warriors, it is just an opportunity to be in your presence and the kind of culture that you create around you. And so really, it's been my opportunity to be a physician who provides medical care for those living with sickle cell disease, to have an opportunity to hear the voice of what needs to change. And so I really have had so many aha moments working with SC Red, because we continue to find opportunities to make a difference, to figure out a way to be advocates for those in the warrior community, to learn about the different myths that exist and to try to dispel them. And then I think to try to recognize the gaps in healthcare, and that includes mental health, that we need to address going forward. So my aha moment is that we need to find a way to make sure that all healthcare providers have an opportunity to benefit from the culture that you have opened up for me.
Thank you. I have one more question. So we have a really diverse audience of like providers, warriors, caregivers, advocates, and so before we take questions, I wanted you to close this out with a call to action for everybody in the room.
So one of the things that I believe we need to understand more is how different aspects of healthcare need to be brought forward. We need to think about not only how to do better, right? And part of that is research, figuring out in studies. And the other part of that is listening to the warrior voice. And so one of the things that this audience needs to understand is there is so much work to be done in sickle cell. We're just at the beginning. And we need to find a way to partner, to work with each other on a single mission, improving the lives of those living with sickle cell.
Thank you. That was perfect. Demetrius, do you have a call to action?
Put me on the spot with that one. I have a call to action. First of all, I just want to say it's amazing to see young black doctors in the building. Let's give a round of applause for that. The call to action for me that I would say, that I would just echo is just have a heart for sickle cell. Be compassionate, listen, and treat us like human beings, like we're relatives. Like that's the one thing that we never see when we get into the hospital. We're treated like patients instead of human beings. You know, we've witnessed animals and dogs and, you know, stuff get better care than actual human beings living with sickle cell. So the call to action is to just have a heart for sickle cell and have a compassion for human beings.
That was perfect, and I'm really glad that you said that because I think, like you said, for a lot of us, we've been kind of boxed in to our diagnosis, and that's one of the things that SU Red is really working hard to prove through our mission, not just the importance of prioritizing reproductive health, but just being seen as whole people. So thank you for saying that. Naya?
Call to action. Well, I say my call to action, I just had a huge aha moment in my life. So I'm a recent graduate with my master's degree, and so I plan on... Thank you. I plan on continuing to pursue my education, and I haven't really made up my mind, but essentially what I understood is when you love yourself, again, you can turn around and love somebody else because people are an extension of ourselves. Like all 7 billion people on this earth are literally an extension of ourselves, right? Like either they're going to be a blessing or a lesson. And so, you know, we are constantly learning out of all of, whether it's a blessing or a lesson, learn from it, right? And so when you learn how to prioritize and love yourself, you can then love the people around you. And by loving the people around you, they can then love on you even harder. And so my call to action is like revolutionary. Love on yourself so you can love on your community. Like lead with love. That's my call to action.
All right. Well, thank you guys. This was incredible. I learned a lot. I am so inspired by all three of you. And thank you for coming every time I call you, especially you, Naya. I know you went through a lot to get here, but I am so proud of you, too. So we have like 6 minutes so we can take some questions.
To Howard University, Roland B. Scott was the first person that I worked with over 60 years ago, when I was 19 years old. But the clap is not for me. It's about Roland B. Scott making us aware that there was a cell that was shaped like a sickle, and that some people that look like me or whoever possibly had the trait or the disease. My issue is, my brother graduated from the school, LaSalle de la Falls Baby and Surgery 2, and my PhD was on the Hill. Both of us graduated the same year. But my issue is with critical race theory. How can we make sure that, and I'm an educator, so it's like that sickle cell is way up on the agenda, not just for people who look like me, but for people who don't look like me. But my child, well, I mean, I'm 75, so my child is not coming right now, but my grandchildren could be on a playground and hear that that child had sickle something, and the other kids would spurn at that child. You see what I'm saying? So critical race theory is not just about history and geography and all. Medical science has to make sure that my Demetrius, okay, and my Naya, but it means purpose in Swahili, my love. I studied Swahili at Howard. So that it is paramount. And that's all I want to say. Thank you. And we have to fight for it, even if we have to go down to Congress, because they're talking about, but my child doesn't need to know that. Yes, they do. Thank you very much.
So in response to what you said about critical race theory and sickle cell, I would say I think that's imperative. And one way that critical race theory can benefit sickle cell is by accurately understanding medical history, right? And so throughout medical history, sickle cell has gained the stigma of being a black disease, when in reality, people from Greece, people from southern Italy, right, and so it's based off mosquitoes spreading the disease and natural selection. And mosquitoes didn't just target one area of the continent of Africa, right? And so when you look through medical history, you see that they started separating thalassemia, Cooley's anemia, and all of these other hemoglobopathies that pair really real with sickle cell. And so I'm not a geneticist, so I can't exactly speak to the conspiracy. To the conspiracy of why they separated as much as they do, but I definitely think critical race theory will help us add a lens to understanding why this separation exists, and adding education to all of the hemoglobopathies so sickle cell can be properly understood within the lens it should be, right? And I just find it really interesting that when white people get sickle cell disease, they stop being white. They are now Mediterranean, when we know as the United States, Greece is the cradle of Western civilization, you know what I mean? It just, it's just hypocrisy for me. And so I think critical race theory can be a tool to really break down that mystery that we have within the Western medicine.
Ray Michael Bridgewater, President and CEO of the Assembly of Petworth. I'm also on the advisory board of the March of Dimes in this region. So this is right on. As a follow-up to what you just said, I'm looking at this from a global health perspective now. So put on the global health hat. From the aspect of, is sickle cell even a bigger problem? Are you seeing cases in Africa, South America, the Caribbean, Southeast Asia? Is it increasing? Thank you.
I can't speak directly to data and statistics, but from lived experience, I can answer that 100% yes. Data, like the statistics of our lives, the data, the numbers are going up for sickle cell, but our quality of life is going down, even though they have research stating how they can extend our lives. That data isn't, or those plans, those trajectories are not being followed. And I would say it's even more critical that we understand sickle cell in places where there aren't healthcare infrastructure to support those patients, right? And so when we think about the continent of Africa, or we think about Haiti or the Caribbean, different places in the Caribbean, if I can only imagine here in the United States, if I'm receiving piss poor care, excuse my language, what are they receiving? So we definitely need to do the work over here in the United States, but this work that we do in the United States for sickle cell should only be a starting point and the foundation for how we talk about the global narrative of what sickle cell is and how it's projected to be done. And I also think that we should not take a eugenist framework of thinking to expel this disease, right? Because my life is just as much worth living as an able-bodied person. And Tiana, Demetrius, we're all examples of our life is just as much worthy with sickle cell as somebody who doesn't have sickle cell. So somebody, two people with sickle cell disease, if they decide that that's the choice they want to take and procreate, we should empower them and create them with family planning so that they can have healthy children regardless of what this disease process looks like.
Absolutely. And I think that one of the things that is really important to understand is that even though sickle cell disease is quote unquote a rare disease in the U.S. with 100,000, 120,000 being impacted, it is a global condition. And 300,000 babies are born every year, primarily on the continent of Africa, living with sickle cell disease. The most common blood disease globally, right? And when you think about the frequency of the gene, right, it is very understandable that although 1 in 12 or 13 African Americans here carry the gene, when you're in Nigeria, when you're in Ghana, it is 1 in 4. So we have the template of demonstrating how to start the process of good health care. We still have a long way to go to get to the optimal health care for those living with sickle cell. But one of the really moments for me today in this building, I did my medical training here in Washington, D.C. And when I was a first year an intern at Children's National, there was no newborn screening. Families were coming with babies to the hospital who were sick and dying without knowing that they had sickle cell. So right now, most of the individuals born with sickle cell disease globally go undiagnosed because the likelihood that a child born with sickle cell on the continent of Africa in certain countries survives to 5 years of age is unlikely because 50 to 90% of them will die before they're age 5. So there's a lot of work that we need to do to bring knowledge that we have gained here in the U.S. globally, but then there's a lot of work we still need to do in the U.S. to make sure that we understand what good looks like for sickle cell and that we make sure that all have access to it.
Oh, okay, I'm kind of along the lines of what you were just talking about. I wonder what the current state is and availability of selective embryo transfer, because that seems to be a viable option for some folks that wish to take it. And is it available or is it prohibitively expensive?
So I think that there's really a couple of different questions in that question. And I just want to make sure that before I answer it, I kind of put it into the right context. So first of all, I think that every couple who wishes to have a child should have the best testing to understand the likelihood of having a child with hemoglobinopathy. And until we get that right, I don't know that we can go into selective implantation from in vitro fertilization. But yes, it is available in the sense that it is possible. Is it accessible? Very unlikely. Because as many of you know, to be able to afford just one cycle of in vitro fertilization with any special testing is usually above $10,000, depending on where you live, when you add all of the expenses associated with the medications, with the process, with having to get back and forth to that specialty care team. And then when you add prenatal diagnostic testing on the embryos, it really accelerates the expense. So what we need to do is to understand what individuals living with sickle cell disease want, to make sure that they know the likelihood, or any individual wishing to have a child, the likelihood of having a child living with a hemoglobinopathy. And if that couple wants to do their best to make sure that that child does not have a hemoglobinopathy, that they have good access to that care, and that if they decide to go through the pregnancy without that, that they can have informed care.
Sorry, one more.
Thank you. That was so beautiful. Thank you, Kim, and everybody else. I just want to give one example, which, not that it's necessarily applicable to U.S. There are few countries which have really conquered sickle cell disease. And one of them, you probably didn't hear much, is Saudi Arabia. Now, Saudi Arabia is a different setting. Most of the marriages are arranged marriages in Saudi Arabia. And most of the medical care is controlled by the government. Most of it is provided through military. Many of the hospitals are run by armed forces. So they have a mandate of mandatory premarital testing. They don't have much extramarital sex. It's not easy. Let's put that. So mandatory premarital testing, and then they go through 2 to 6 hours of mandatory counseling based on that testing, those who are at risk, who have at risk. And they have reduced the incidence, the new babies born, by 92%. And I think that's a great success. Now, I'm not saying that that model is going to work, but the model of informed decision-making with adequate education and all the options before we engage in activities which would result in a baby having sickle cell disease, I think it's an important thing, important message.
I agree. I think we need to do our best to provide access to that kind of care.
I'm so encouraged by all of you. I'm Elle Cole. I'm a mom of a 14-year-old that is living with sickle cell disease. And my question to you is, how can caregivers better educate their children who are warriors to ask targeted questions of their providers as they go through adolescence while living with sickle cell disease?
That's a great question. I think it's good for the adolescent pediatric child to understand their body with sickle cell and their triggers. I think when the child best understand their body with sickle cell, they're able to articulate how they feel to their professionals. And so one thing I would say is have the talk. As a caregiver, I believe it's from a patient's perspective, I believe that the caregiver should be doing as much education as the patient. So the caregiver, if you have a pediatric child, adolescent child, that you should be educating them on the sickness that they're going through. You should have a more of an understanding of they do with their illness, that way that you can coach them. We all need coaching and education, so just simply having to talk with them in layman terms. We don't have to be so medical terminology when it comes to sickle cell, but for kids, they need to understand layman terms, and I figure that comes well with understanding triggers and what sets off your sickle cell. That way you can better articulate when it comes to your medical professionals.
And I just like to piggyback on both of those comments because I think it is a two-way street. And I think that the provider needs to make a point across the lifespan of giving the family the opportunity to ask questions. The young person in the room hears that. You know, kids are so observant. And literally, I have some families because they model and they know that I'm always going to turn to that child and ask them, do they have any questions for me before they leave? And so starting at very young ages, some of my parents start their kids at 5, say, what question do you have for the doctor today? And giving them that voice, modeling that this is a two-way street. That we're here to exchange information that helps us as a team, provide the best care, not only when they're sitting in that office in the clinic space, but when they're at home, when they're at school. Yeah.
Yes, I definitely want to piggyback off of everything that you guys said, and definitely say when you have a chronic illness as a young black person in America, it's a level of layered oppression that you have to learn how to navigate. And so because with a chronic illness, you miss a lot of school, the providers should do their due diligence in creating an an educational environment to encourage this student, not only a patient, but this student, this child, like in every other identity that they have to navigate, they should encourage this person to definitely use education as a tool as self-expression, right, and not just indoctrination. And when you do that, you can inspire the learner in that patient, right? And so when we inspire learners, they then are encouraged to ask the questions that they're burning to ask. But one of the other barriers to why we don't ask questions is because there's a power imbalance. So what is the physician doing to try and break down that power imbalance to make the families feel comfortable enough? Because a lot of, especially as African Americans, we don't feel like we're experts in our own experience because we don't have as much schooling, we don't have as much access to wealth, it's a lot of we don't haves, right? But what do we have, right? And the things that we do have, we can empower ourselves to then use those things to our advantage, to then, show up authentically in these spaces and ask questions that are truly burning to us. So I think that's one way you can definitely encourage a baby girl to, create a relationship with their healthcare provider, and starting with creating this pediatric relationship will then, really encourage them to, when they transition into adult care, to have healthy relationships with their provider, and they have healthy expectations of what their provider is able to provide.
Well, thank you so much.